Okay, today the topic of our lecture and the video today is about hypertension in pregnancy, diagnosis, and management. So, we will study in detail NICE guidelines. Now, these are the contents, it's quite long, but we will discuss it in detail. Okay, first, reducing the risk of hypertensive disorders in pregnancy. Symptoms of preeclampsia. Advise pregnant women to see a healthcare professional immediately if they experience symptoms of preeclampsia. Symptoms include severe headache, problems with vision such as blurring or flashing before the eyes, severe pain just below the ribs, vomiting, sudden swelling of the face, hands, or feet. Now, antiplatelet agents. Advise pregnant women at high risk of preeclampsia to take 75 to 150 mg of the aspirin daily from 12 weeks until the birth of the baby. Women at high risk are those with any of the following: hypertensive disease during a previous pregnancy, chronic kidney disease, autoimmune disease such as the systemic lupus erythematosus or antiphospholipid syndrome, type 1 or type 2 diabetes, chronic hypertension. Okay. Now, advise pregnant women with more than one moderate risk factor for preeclampsia to take 75 to 150 mg of aspirin daily from 12 weeks until the birth of the baby. Now, factors indicating moderate risk are first pregnancy, age 40 years or older, pregnancy interval of more than 10 years, body index, mass index of 35 or more at first visit, family history of preeclampsia, multi-fetal pregnancy. Other pharmaceutical agents. Do not use the following to prevent hypertensive disorders during pregnancy, that is, nitric oxide donors, progesterone, diuretics, low molecular weight heparin. Nutritional supplements. Do not recommend the following supplements solely with the aim of preventing hypertensive disorders during pregnancy, that is, magnesium, folic acid, antioxidants, vitamin C and E. Fish oils or algal oils and garlic. Diet. Do not recommend salt restriction during pregnancy solely to prevent gestational hypertension or preeclampsia. Lifestyle. Give the same advice on rest, exercise, work to women with chronic hypertension or at risk of the hypertensive disorders during pregnancy as healthy pregnant women. Now, diabetes. For women with pre-existing diabetes or gestational diabetes, see the NICE guidelines on diabetes in pregnancy, and we will discuss this in another video. Now, assessment of proteinuria and hypertensive disorders of pregnancy. How you are going to assess the proteinuria? So, interpret proteinuria measurement for pregnant women in the context of the full clinical review of the symptoms, signs, and other investigations for preeclampsia. Use an automated reagent strip reading advice for dipstick screening for proteinuria in a pregnant woman in secondary care settings. Now, if dipstick screening is positive, that is +1 or more, then we will send patient ACR or PCR to quantify the proteinuria in the pregnant woman. Do not use first morning urine void to quantify proteinuria in the pregnant woman. Do not routinely use 24-hour urine collection to quantify proteinuria in pregnant women. If using creatinine ratio to quantify proteinuria in pregnant women, use 30 mg as a threshold for significant proteinuria. If the result is 30 or above, there is still uncertainty about the diagnosis of preeclampsia. Consider retesting on a new sample alongside the clinical review. If using SCR as an alternative to PCR to diagnose preeclampsia in pregnant women with hypertension, use it as a diagnostic threshold. If the result is 8 or above, there is still uncertainty about the diagnosis preeclampsia. Consider retesting or a new sample alongside clinical review. Okay, now management of the chronic hypertension in pregnancy. Chronic hypertension which present prior pregnancy. Pre-pregnancy advice. Offer women with chronic hypertension refer to a specialist in hypertensive disorders of pregnancy to discuss the risk and benefits of treatment. Advise women who take angiotensin converting enzyme inhibitors or angiotensin 2 receptor blockers so that there is an increased risk of congenital abnormalities if these drugs are taken during pregnancy. To discuss alternative antihypertensive treatment with the healthcare professional responsible for managing their hypertension if they are planning pregnancy. To discuss alternative treatment with the healthcare professional responsible for the managing their condition if AC inhibitor ARBs are being taken for other conditions such as renal disease. Stop antihypertensive treatment in women taking AC inhibitors or ARBs if they become pregnant, preferably within 2 working days of notification of pregnancy, and offer alternatives. Advise women who take thiazide or thiazide diuretics. There may be an increased risk of congenital abnormal neonatal complications if these drugs are taken during pregnancy. To discuss alternative antihypertensive treatment with the healthcare professional responsible for managing their hypertension. So if they are planning pregnancy, advise women who take antihypertensive treatments other than AC inhibitors, ARBs, thiazide diuretics that are limited where it's available has not shown increased risk of congenital malformation. Treatment of chronic hypertension. Now, how you are going to treat chronic hypertension? So, offer pregnant women with chronic hypertension advice on weight management, exercise, healthy eating, lowering the amount of the salt in their diet. Provide this advice in line with NICE guidelines on hypertension adults diagnosis and treatment. See, continue with existing antihypertensive treatment if safe in pregnancy or switch to an alternative. So sustained systolic blood pressure is less than 110. Sustained diastolic blood pressure is less than 170. The woman has symptomatic hypertension. Offer antihypertensive treatment to pregnant women who have chronic hypertension and who are not already on treatment if they have sustained blood pressure of the systolic greater than 150, 140, sustained diastolic of the 90 or higher. When using medical to treat hypertension in pregnancy, aim for target blood pressure of the 135/85. Consider labetalol to treat chronic hypertension in pregnant women. Consider nifedipine for women in whom labetalol is not suitable. Methyl dopamine, both labetalol and nifedipine are not suitable. So base the choice on any pre-existing treatment side effects. Offer pregnant women with chronic hypertension aspirin 75 to 150 mg once daily for 12 weeks. Offer placental growth factors ways to rule out preeclampsia between 20 weeks and 35 weeks. Antenatal appointments. Weekly appointments if hypertension is poorly controlled. Appointments every 2 if handling well controlled. Timing of the birth. Do not offer planned early birth before 37 weeks to women with chronic hypertension whose blood pressure is lower than 160/110 or with without antihypertensive treatment unless there are other medical. So no planned early birth before 37 weeks. For women with chronic hypertension whose blood pressure is lower than 160/110, with or without antihypertensive treatment, timing of the birth and maternal fetal indication for birth should be agreed between the woman and senior obstetrician. So if planned early birth is necessary, offer a course of antenatal corticosteroids and magnesium sulfate in line with NICE. Postnatal investigation.